Thank you, Dr. Landreth, for a very interesting presentation on some of the perils of vaccines for Alzheimer's disease therapy. We're now going to have a series of debate questions back and forth between the two speakers, Dr. Morgan and Dr. Landreth.
So, Dave, do you think you can modify this immunotherapy approach to avoid these perils?
Well, there certainly have been increasing attempts to try and do that. One of the ways in which this has been done with active immunization is to modify the vaccine itself, to try and generate a vaccine that is less likely to activate T cells that would then invade the brain and produce this meningoencephalitic problem. So that's one approach that's been attempted, and there may be some success in that regard. However, a second approach is even with the passive immunotherapy. One of the problems that you mentioned that we've observed was the microhemorrhage that was observed with passive immunotherapy. And one of the things that we found is if we modified the antibody itself to some degree, we could actually diminish the degree to which the microhemorrhage occurred. And this was by removing the carbohydrate domain from the antibody, something called deglycosylation. I think there's also attempts to develop antibodies that are against specific parts of the A-beta peptide, and some of these may have properties that others don't. And identifying which properties cause these perils will help us in minimizing these in the ultimate therapies. So let me ask you a question, Gary. Given all of these perils, do you think that there is ever a chance for an amyloid-lowering therapy to somehow be effective in treating Alzheimer's, or should we just give up on all of them because of all these perils?
So, Dave, I think that the data from the mouse models of Alzheimer's disease vaccination therapy has shown rather dramatic effects, which gives great hope for the use of immunotherapy to improve cognition. Now, conversely, I think that there are a number of concerns. Most recently, David Cribbs' lab has reported that in aged dogs, although immunotherapy was associated with reduction in A-beta and plaque levels, these animals were not cognitively improved. Similarly, the analysis of the data from the human trial shows that in two cases, there was complete removal or significant removal of amyloid plaque from the brain. But these patients were in fact no different from untreated controls in their cognitive abilities. So I think that it is an open question whether amyloid therapy is going to be efficacious in improving cognition in humans. So, Dave, based on what we know from both the clinical and the animal data, when do you think therapy should be initiated in humans?
Well, the answer to the question is probably fundamentally the same as for every other disease, as early as possible. However, there's going to be some difficulty in taking the entire population at risk, which is largely the entire population over the age of 50, and giving them monoclonal antibodies or even active immunization against the A-beta peptide. We know that while the flu vaccine does show some benefit in older patients, obviously not everyone still goes and gets a flu vaccine, even though the risks are quite high once you get the flu of having serious illness. I think that one of the groups that may be the most likely to benefit from these disorders are those that have genetic predispositions towards Alzheimer's disease, where we could catch them at an age before the plaques have started to develop, maybe 10 or 20 years before the disease starts. These would be the familial cases that have genetic mutations, and it might also include Down syndrome patients, where we know that the risk is very high, and therefore it might be acceptable to have a certain degree of peril possibly associated with the treatment, given that the certainty of the disease onset is so high. My opponent in this debate has done a very nice job of outlining a number of the potential perils associated with immunotherapy in the treatment of Alzheimer's disease. However, most therapies that we have today come with some degree of risk. There are no risk-free therapies. We know that cardiovascular disease often responds well to heart surgery, but there are certainly risks and adverse events associated with heart surgery, similarly with most medications. And so the question that I have is, what degree of risk might in fact be acceptable for a disease like Alzheimer's? I mean, if cancer chemotherapy causes you to become systemically ill in order to cure you, to what extent could we accept a similar sort of response in an Alzheimer population?
So I think this is a rather critical question. So Alzheimer's is a devastating progressive disease, and I think most people would accept some risk associated with therapy. But I think critical in this discussion is that the patient population needs to be educated to exactly what the risks associated with these therapies are. And today we do not have a clear vision of what these risks are. And I think that remains one of the major challenges to implementing this therapy in the population. And I think this is also a personal decision, and that different individuals find different levels of risk acceptable. But given the nature of the disease, I think it's predictable that most people would accept problems and adverse events to some degree in the implementation of this therapy. But again, I think this is as a personal decision that each of us will have different answers to.